Hello guys, this is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, today I was allocated in a theater where they do neurosurgical cases. So we are going to talk about that case. So obviously, for ethical reasons, we're not going to divulge the information of the patient. We're just going to talk about the age, just going to mention the age and the diagnosis. So the idea is not to know the personal information about the patient, but is to share information for teaching purposes and just to help each other and to help the students, and also to make sure that you pass your anesthesia well, and also when you go out there you know exactly what to do, and that obviously will help you as a doctor and will improve the lives of the patient that you're going to be seeing. So that's the whole idea, helping each other understand clinical medicine. So guys, this patient, so we said it's neurosurgery. So remember, as an intern or as a student, you are gonna go to a theater where they do ortho, go to a theater where they do abdomen, where they do ENT, where they do ophthalmology, where they do Euro cases. So the important thing is that you need to understand the different approaches depending on the kind of operation. It's very important. Ne? So this is a neurosurgical case. So this patient is a 26-year-old male patient. So his diagnosis was that he had an epidural hematoma. He had an epidural hematoma. Now, if this scenario, let's say they were giving you this, I'm talking to the students now, if they had given you this scenario in an exam, they say, what is your anesthetic approach? At this point, we don't care about the surgical approach. It's for surgeons, but we care about the anesthetic approach. What would be your approach to this patient? What is important is, when they give you a scenario, so I'm going to talk about this patient and also put a bit of like, how would you answer questions in the exam? So when they give you a case, what you must decide, the first thing is that you must decide based on the information whether you are dealing with an emergency or whether you are dealing with an elective. Because you don't want to okay, let me just finish it off. So the reason why you want to decide, you want to know whether it's an elective case or it's an emergency, you want to know which sequence are you gonna use or are you gonna apply in this patient. This one is rapid sequence. This one would be an elective sequence. The thing is, if you mess it up there on the exams, everything is gonna be wrong, because if a patient is supposed to be done in a rapid sequence, but you didn't realize that they are in emergency, they need rapid sequence, and then your anesthetic approach is that of an elective sequence, everything is gonna be wrong. Whatever step that you're gonna be mentioning is gonna be wrong. So that's how crucial it is. So when they give you a scenario, read through it and decide. So if it's rapid sequence, this patient is on this side. It was an admitted patient. By a rule of thumb, an admitted patient is a fasted patient. It's a fasted patient. It's been in the hospital, and everyone in the ward, they knew that this patient is gonna go for operation tomorrow, so they have fasted that patient. So you don't have to worry about. So this is our patient. Let's talk about our patient. The second thing that you must ask yourself after this is the first question. The second thing is, where is the operation? Where is the operation? It's what I've just explained on the video, that in the legs, lower down the lower abdomen, buttocks, around the perineum, you can do a spinal. But this patient had to be operated in the head. So that because it's a head, we have to go for a GA. So we have answered two crucial questions based on the information that we have. Based on the information that we have. So we know that we're gonna do a GA, and we know that we are gonna do an elective sequence. That's what we know. Now we can start talking about what are the drugs that we're gonna be doing, that we're gonna be giving. So this is part of the pre-op. These are the things that you go beforehand. You make sure that the patient is gonna fast. You make sure that you know the nature of the procedure and where is it in the body and all of that, so that by the time the patient comes in the morning or whenever, you already have prepared your drugs. You know exactly which drugs you're gonna be using. Okay, so now let's get to what did we do for this patient. So when the patient came in, all patients when they come in, like I always say, this you don't have to wait for a senior to do. When the patient comes in, the minute you remove him, you transfer him from the stretcher onto the operating table, the first thing is you attach the monitors. Attach monitors. And the monitors that we always attach, the basic ones, is the NIBP, is non-invasive, right? Is the pulse oxy, is the so just say sets probe, and then also we attach the ECG leads, ECG. After attaching those monitors, someone else obviously will be doing, if you're alone, then you're gonna check your IV line. If the patient does not have an IV line, you're gonna have to insert an IV line. If the patient has an IV line, you're gonna go and make sure that it's running. Look at it, flash it, and see if it's running. You don't want a line that is not functional and you have already given drugs. It's gonna be hard to resuscitate that patient. So after doing that, after attaching the probe, get readings before you give anesthesia, because you want your baseline readings, right? You want to know your baseline readings. This is what we did, guys. This is what we did. And this is what you're also gonna do when you go to theater and do anesthesia. See, this is clinical medicine. It's what are you gonna do when you have a patient. So, IV line, and when you insert an IV line, make sure that you go for a gray. It's always difficult to get in a gray, especially in females, and if you can't get a gray, get a green. If you can't get a green, get a pink. You can't go lower than that. That is for adults now. Okay, now our equipment is there and our drugs were already drawn by the senior before I even came. So now we're ready. So pre-oxygenation, and you know, seniors are impressed by small things, small things. When he comes or she comes, you attach the monitors, Obviously, they will guide you and remind you of the other things. Attach monitors, look for a line, and also pre-oxygenate. You know how to pre-oxygenate, you know how to make the C, you know where to hold the jaw. So simple things like that. Because if you can know those things, then they will know that, okay, you are a bit advanced in terms of what they will need to teach you. So they know exactly where to start with you. But if you struggle with everything, you're just sitting there, then it becomes a different things, a different kind of becomes a difficult situation. So you pre-oxygenate, and we have said that you give 100% oxygen. I'll put a link on the video. Why do we pre-oxygenate? What's the thinking around? What's the idea around that or behind that? So after pre-oxygenation, now these are the drugs that this patient got. Got fentanyl and propofol and then so the propofol was the IV induction agent that was used. Rock served two purposes in this patient. The first was to facilitate intubation. Right? Number two, it was just used as a muscle relaxant, because you want that patient to relax. I don't know what better word to use for that. So, and the students that were there, we had to wait for about 3 minutes before we could intubate. And then after waiting, we intubated the patient. Intubation. The ET tube that we used was size 7. After confirming that it was in situ, so you need to know what are the things that you check to confirm that the tube is inside. So we secured 8, 9. So now after everything went well, patient now is sleeping, airway is secured. It was now a matter of positioning the patient, making sure that it is in the right position for the surgeons, so that the surgeons are also happy. Now, this patient was maintained on isoflurane. So this was the anesthesia was maintained. Because remember, you induce anesthesia, you maintain anesthesia, and you wake up the patient. So these are the steps. Now you're gonna see your senior holding about 3 or 4 different drugs and pushing all of them. You wonder, what was he giving? So those are the drugs that he was giving: the fentanyl, the propofol, the rocronium, and yeah. So this is the sequence of events. This is how everything happened. Now, the other drugs that we gave, the other drugs that were used in the operation, the other drugs that were used are not anesthetic drugs, but are other drugs. So ceftriaxone as an antibiotic was used, and then the surgeons did complain at some point that the patient was bleeding a lot, so we gave cyclocapone. Psych. No, I can't spell. So cyclochrome. So this is just for to stop bleeding. It's an antibiotic. So unfortunately, I stayed for about 2 hours with this patient. So I left the patient because I was starting my post call at 11. But the patient was doing well and the surgeons were almost done, but it's just that I had to go. So this is what happened with this patient.